Can you hear me?
Yeah.
I'm going to take my mask off because I feel like I project better.
Yeah.
So, and then Q&A for about 15 minutes.
Okay.
And
yeah.
And it looks like Nora is here.
Hi, Siri.
Laura,
Nice
how are you?
And Grace, are we already letting people in?
Yeah.
Okay. Sorry, now everybody gets to see the.
So Sarah, I was just glancing at your introduction. You should definitely know.
Okay.
I feel like our time is short.
Yeah.
Yes. Looks very nice.
Okay, so I think we'll get started a little bit early, but I'm worrying about, we have everything working, so I just want to make sure we can go with it. Welcome to our first hybrid seminar series for spring quarter, and very big thank you to Taylor from Population Health Initiative, who has been a wonderful support for us throughout and getting us to this point. Welcome to everybody who's here in person. Before we get started, I wanted to read off a land acknowledgement and a few other acknowledgements. So as we know, the University of Washington sits on the occupied homelands of the Coast Salish peoples, and CSDE acknowledges we are on that territory, which is the traditional homeland of the Duwamish, Suquamish, Tulalip, and Muckleshoot nations and other native peoples. I'm grateful to live and work as a guest on these lands. And this land acknowledgement is just one small gesture in the ongoing process of working toward repairing and sustaining relations with the Coast Salish lands, waters, peoples, and other non-human kin. Additionally, CSDE is grateful for the artistry of Native artist and former UW professor Marvin Oliver, who was commissioned to design our logo and whose logo reflects the mission of CSDE and the vital connections to Native peoples and territories. I'd also like to say that today's talk was made possible through generous support from the UW Department of History, UW's African Studies Program, UW Department of Anthropology, the UW Department of Global Health, the UW's Population Health Initiative, and a grant from the Eunice Kennedy Shriver Institute for Child Health and Human Development. I'd like to remind everyone about how our webinar and this hybrid seminar will work. For those of you online, please post questions or comments in the Q&A function at the bottom of your screen. And you can post them throughout. We'll get to them at the end. We'll attend to them at the end of the talk. And you'll have an opportunity to actually ask your question. We'll bring you into the chat and have you ask your question online. For the live audience, just please raise your hand. Immediately following the seminar, there will be a post-seminar discussion with Dr. Sue, moderated by Larissa Ojeronsky, who is going to be online. And we'll drop a link to that webinar in the chat box for everyone to join. So that'll be a new link, as I understand it. Right. Introducing Dr. Sue is Professor Lynn Thomas, who is a historian of politics and gender in East and Southern Africa. She teaches courses on African history since the 1880s, the global history of AIDS, comparative colonialism, and comparative gender. Currently, her research interests include transnational reproductive politics and the politics of natural resource control. She's written several books, and I'll just list a couple of them. Her first book was The Politics of the Womb, Women, Reproduction in the State in Kenya, which was published in 2003 by UC Press. She's also been an editor or co-editor of 2 volumes, The Modern Girl Around the World, Consumption, Modernity, and Globalization, which was published by Duke University in 2008. And then in 2009, a co-edited volume on Love in Africa, published by the University of Chicago Press. And then her latest book, Beneath the Surface, which was co-published by Duke University and Wits University in 2020, is a transnational history of skin lighteners centered in South Africa that extends into the broader Southern African region, East Africa, and the United States. So she's a wonderful person to be helping host this seminar, and I'm so glad we were able to partner on this event. And welcome, Professor Sue, and I'll turn it over to Lynn.
Great, thank you so much, Sarah. So it is my great pleasure to introduce Assistant Professor Siri Sue from Brandeis University. Albeit today she's joining us from Dakar rather than Boston. So Professor Sue is a medical sociologist whose research interests include global maternal and reproductive health, population and development, and feminist and post-colonial studies of science, medicine, and technology. Professor Sue earned her MPH and her PhD at Columbia University. After she finished her MPH, but before she pursued her doctorate, she worked for several years in Senegal for an NGO, Management Sciences for Health, where she partnered with people in the Ministry of Health in Senegal to try to improve child and maternal health. So thus she began her PhD research on post-abortion care in Senegal with a very deep understanding of the challenges and the silences that Senegalese women faced in seeking safe abortion care. Many of those challenges and silences, of course, relate to the long arm of US policy and the 1984 Mexico City policy specifically, normally known as the global gag rule. So Professor Sue's research has been funded by many important and prestigious organizations, including the American Association of University Women, the American Council of Learned Societies, the Social Science Research Council, and the National Institute of Child Health and Human Development. And currently, she has a very large grant from the Hewlett Foundation for a truly innovative global South-North collaborative project where she's working with colleagues in Burkina Faso and in Senegal on a study of misoprostol or medical abortion in those two Francophone West African countries. So that is the next project that she's already working on. So I first learned of Professor Sue's amazing research and her many articles published in the likes of Social Science and Medicine, Medical Anthropology, Global Public Health, and Frontiers of Sociology a few years ago from my UW colleague, Nora Kenworthy. And then last summer, I had a chance to read Professor Sue's new book, Dying to Count, Post-Abortion Care and Global Reproductive Health Politics in Senegal. So the book was just published last year by Rutgers University Press. So Dying to Count is a stunning piece of scholarship, and I'm so glad that you're going to hear directly from Professor Sue about that research today. But before handing the floor over to her, I wanted to just mention two things that I think make Dying to Count such an important and impressive study. So the first is Professor Sue's careful and compassionate study of the providers who ultimately deliver post-abortion care in Senegal. Through meticulous ethnographic research, she simultaneously shows the considerable material and political constraints that those providers work within, and then the ways that those constraints often result in patients receiving inadequate care. Second is Professor Sue's deep commitment to reproductive justice, an approach pioneered by women of color activists and scholars. So every step of the analysis in the book, every step of her analysis of post-abortion care in Senegal is guided by a keen attention to how inequalities of gender, race, class, and ability really constrain people's capacity to lead healthy reproductive lives. So please join me in welcoming Professor Sue to the University of Washington.
Thank you so much, Lynn, for that very generous introduction. And I will go ahead and share my screen. Ooh, nope, not it. There we go. So Thank you for inviting me to speak at the University of Washington Center for Studies in Demography and Ecology. As Lynn said, I'm joining you today virtually from Senegal, where I conducted the research for my recently published book on the global history and politics of post-abortion care in Senegal. And we can see in the image on the left of this slide here, an excellent representation, an excellent representation of the global post-abortion care model as a form of harm reduction related to complications of incomplete abortion, right? We see a midwife rather than a physician at a district hospital. And the fact that she's at a district hospital is also salient because she's not at a tertiary hospital. She's using a plastic manual vacuum aspiration or MVA syringe rather than doing sharp curettage or dilation and curettage or DNC to conduct uterine evacuation. And so in today's talk, I'll be talking about how this global model of reproductive health care has been implemented and evaluated in Senegal, but much of this work is relevant to other contexts in sub-Saharan Africa, where post-abortion care is purportedly available in hospitals, where the US government is a prominent donor of family planning and global health aid, and where women face an incredibly high risk of injury or death, whether they terminate their pregnancies or carry them to term. And my work draws on the theory of reproductive governance, which refers to the actors, institutions, discourses, technologies, and indicators involved in monitoring and regulating reproduction. Through national legislation around abortion or contraception, or global health and development treaties like the International Conference on Population and Development, or the ICPD, the Millennium Development Goals, or the Sustainable Development Goals. Many of you have likely heard of the 1984 Mexico City policy, also known as the Global Gag Rule, which requires NGOs in foreign countries to sign a document agreeing that if they receive US family planning aid, they will not use from other sources toward abortion-related activities. The Global Gag Rule has been really influential in terms of a medium of global reproductive governance, given the role of the US Agency for International Development, or USAID, as the most generous donor of global family planning aid. Between 2003 and 2013, USAID accounted for over 2/3 of all family planning aid. Reproductive governance also unfolds through the production and distribution of standardized demographic indicators, such as the maternal mortality ratio. National governments and NGOs are evaluated and rewarded, and at times shamed by the extent to which they are meeting or missing national or global benchmarks. The United States, for example, is one of only 2 developed nations where the maternal mortality ratio has increased in the last 20 years. When it comes to the maternal mortality ratio or other reproductive health indicators, we have to pay attention to what these indicators are revealing or obscuring about reproductive health care. Medical anthropologist Claire Wendland, for example, has argued that in countries like Malawi, the maternal mortality ratio reveals very little about the actual technical environment in which health professionals administer delivery care. Yet, declines in Malawi's maternal mortality ratio purportedly signal advances in maternal health care that in turn convey competent population stewardship on the part of the health minister and other politicians and stakeholders. So reproductive health indicators are multivalent, serving multiple purposes, not all of which necessarily center women's health, dignity, and safety. Post-abortion care is connected to a number of global regimes of reproductive governance. Starting in the mid-20th century, demographers, economists, and development experts urged the need to curb population growth in the global South. High fertility was understood as an impediment to economic growth, and it was also thought that high fertility would result in political instability and environmental degradation. And so population control in the form of contraception was promoted as a technical, medically controlled solution to this problem. And the USAID distributed not only contraception to countries in the global South, but also abortive technologies like the manual vacuum aspiration syringe. Now, all of this came to an end in 1973 with the Helms Amendment, which prohibits foreign assistance from being used for the performance of abortion as a method of family planning. And the Helms Amendment is still in place. In 1987, the Safe Motherhood Initiative called for greater attention to the problem of maternal. The Safe Motherhood Initiative argued that the focus on fertility reduction promoted by the population control paradigm was too narrow, and that the global health community had to invest in pregnancy and delivery care, and not just in urban hospitals, but also at lower levels of. Several years later, in 1994, 179 countries signed the Program of Action of the International Conference on Population and Development, or the ICPD, which recognized reproductive health or well-being as a human right for the first time. And the ICPD rejected top-down, target-oriented approaches to fertility reduction, arguing instead that comprehensive approaches to sexual and reproductive health that centered women's needs were key to economic development. Post-abortion care is embedded in more recent global regimes of reproductive governance, such as the Women Deliver and Family Planning 2020 initiatives. And Women Deliver emerged in 2007 with the purpose of recentering global commitments to maternal health through evidence-based approaches. It prioritized statistical evidence from randomized controlled trials, so clinical testing of drugs and techniques, or what critical scholars of maternal health care have referred to as a narrowing of the evidence base of what works when it comes to reducing maternal death, rather than the comprehensive approach envisioned by the Safe Motherhood Initiative 20 years earlier. Family Planning 2020 appeared in 2012. A sense of crisis among global health stakeholders that family planning needed to be reprioritized in global health. Donors and NGOs committed to providing 120 million women in the world's poorest countries, most of which are in Africa, with contraception by 2020. And Family Planning 2020 has been framed as a form of reproductive rights. But feminist activists and scholars have argued that it represents a return, a brazen return, to the target-based approach of Cold War era population control. Donors, NGOs, and pharmaceutical companies work together to test and promote long-acting reversible contraceptives like Ciana Press, which you can see here. And Ciana Press is a self-administered form of Depo-Provera that has been disseminated in countries like Senegal in order to meet the goals established by the Family Planning 2020 initiative. So my book tells the story of the global post-abortion care model, which was conceptualized by reproductive health NGOs in 1991. So right between the 1987 Safe Motherhood Initiative and the 1994 ICPD. And post-abortion care entails emergency obstetric care for complications of spontaneous abortion, also known as miscarriage, or induced abortion, followed by family planning counseling and service provision to delay the woman's next pregnancy. And in the aftermath of the 1984 global gag rule, post-abortion care was understood as a harm reduction approach to the problem of unsafe abortion. It rendered complications of abortion a clinical matter to be managed by health professionals rather than a legal or moral issue. The post-abortion care model called for safer, more effective, and less expensive methods of abortion care instead of sharp curettage or dilation and curettage, or DNC. Post-abortion care providers were trained to use the manual vacuum aspiration syringe, which can be used by mid-level providers at lower levels of the health system. And so the ICPD called on governments in countries with restrictive abortion laws not to liberalize abortion, but to ensure the availability of quality post-abortion care as a public health measure to reduce maternal mortality. And so post-abortion care was codified as an intervention grounded in reproductive rights. Post-abortion care is the only abortion-related intervention that is exempt from the global gag rule, and the USAID has provided support for post-abortion care up to $20 million in 40 countries since the early 1990s, and there are currently about 60 countries with post-abortion care programs worldwide. Post-abortion care, and I'll start calling it PAC at this point, has been framed by donors like USAID as a public health success. For example, USAID supported the 2016 publication of a global review of 20 years of post-abortion care evidence that highlighted the role of the manual vacuum aspiration or MVA syringe, and more recently, misoprostol, in reducing abortion-related morbidity, and also the role of post-abortion care in increasing family planning uptake and, by extension, contraceptive prevalence. Despite considerable support for post-abortion care as a maternal health intervention since the mid-1990s, there is considerable variation within and between countries with respect to access to and quality of care. In 2018, the Lancet Global Health published an assessment of PAC services between 2007 and 2017 in primary and referral level facilities in 10 developing countries. And the study found significant gaps in health systems' capacity to offer basic and comprehensive post-abortion care. For example, in 7 out of the 10 countries, less than 10% of primary level facilities could offer basic post-abortion care, including uterine evacuation. And in 2020, the Guttmacher Institute estimated that more than 20 million women in low and middle income countries who've had unsafe abortions and need post-abortion care, among these women, only about 60% of them receive it because of low quality health systems. So in response to this 2018 study, the Lancet Global Health published a commentary that framed post-abortion care as a missed opportunity for women's health and urged policymakers to increase the provision of post-abortion care. So my book tells the story of post-abortion care as a form of global reproductive governance in Senegal. And one of the primary claims of the book is that reproductive governance is not limited to laws and policies issued by national policymakers or donor agencies, but also unfolds numerically as medical workers, health officials, and NGO personnel very pragmatically deploy epidemiological and demographic data to establish facts about what post-abortion care technologies accomplish in hospitals, the kinds of women who receive obstetric care in government facilities, the kinds of interventions that work in reducing maternal mortality, and the kinds of care that Senegalese women are entitled to receive. So in addition to tracing the history of how and why PAC was implemented in Senegal, the book explores what PAC provision entails in government hospitals. And this brings forth another major claim of the book, that an intervention that has been defined in terms of harm reduction and reproductive rights in everyday practice perpetrates harm against women. We see the harm exercised upon women's bodies through discriminatory practices in hospitals, especially towards unmarried and low-income women, and through poor quality of care, including delays in care and the use of unsafe techniques. At the same time, we see how health workers, NGOs, and donor agencies very pragmatically assemble post-abortion care data to convey commitments to maternal mortality reduction goals while obscuring the frequency of unsafe abortion and the inadequate care women with complications are likely to receive in government facilities. So through attention to clinical, technological, and quantification practices of post-abortion care, I explore how this intervention has been evaluated, and most importantly, how and why this intervention remains in place despite a lack of rigorous statistical evidence that it effectively reduces maternal mortality. And so this approach permits much needed reflection on the politics of data and evidence in global reproductive governance, and more importantly, in the achievement of reproductive justice. What do metrics and indicators and the processes and practices of quantification more generally tell us about what health interventions accomplish and whose interests they serve? So this research was conducted over 19 months between 2009 and 2011, and I conducted in-depth interviews with health workers, health officials, NGO workers, and other stakeholders. I observed PAC services and reviewed PAC records at 3 hospitals around the country. I also studied newspaper accounts of women who'd been hospitalized for complications of illegal abortion and reviewed cases of abortion that were prosecuted by the state in the region of Dakar between 1987 and 2010. And the most recent data on abortion in Senegal come from a study published in 2015. And the data suggests that abortion is common and that up to 63% of abortions are what public health experts would consider high risk. Up to 42% of women with complications do not receive care, with rural and urban poor women being least likely to receive care. And most post-abortion care is administered in district and regional hospitals. And in a little while, I'll share some information about the cost of post-abortion care. Now, Senegal has been dubbed the PAC pioneer of West Africa because of how it decentralized PAC services from large urban hospitals to district hospitals in rural areas. Senegal's penal code forbids abortion under any circumstance, but the Code of Medical Ethics permits therapeutic abortion, which in practice happens infrequently. After piloting post-abortion care in several urban hospitals in the late 1990s, the Senegalese Ministry of Health began to introduce the intervention to hospitals at lower levels of the health system. Management Sciences for Health, an international NGO based in Massachusetts, contracted with USAID between 2000 and 2006 to support the Senegalese ministry in improving maternal health and also in increasing contraceptive uptake. And this included the introduction of natural family planning methods like the standard days method cycle beads displayed in the bottom right corner. So starting in 2003, Management Sciences for Health supported the decentralization of PAC in 5 of USAID's regions of intervention. And I worked with Management Sciences for Health as a University of Michigan population fellow during this time and provided support for monitoring and evaluation of PAC. And I also piloted these cycle beads, but that's perhaps a story for the discussion. The previous approach to treating abortion complications involved doctors using DNC in the operating theater. So with PAC, midwives were trained to use MVA. And so post-abortion care was happening in delivery rooms and in some hospitals, separate rooms for MVA. And the data from these hospitals showed the public health impact of replacing DNC with MVA and with task shifting from physicians to midwives. More women were being treated with MVA. Hospitalization periods following treatment were declining, patient costs were declining, there were fewer complications following treatment, and midwives were very comfortable using MVA. So post-abortion care was conceived as a form of public health harm reduction in response to global anti-abortion funding mechanisms like the global gag rule and, of course, restrictive national abortion laws. However, my observations of post-abortion care in hospitals revealed troubling implications of clinical care and discriminatory, humiliating, and neglectful practices, or what some scholars refer to as obstetric violence. When suspected of illegal abortion, women often endure the humiliation of what is widely understood among Senegalese practitioners as l'interrogation, during which they would ask questions at times in full view of everyone in the delivery room about how, when, and where, and why the pregnancy loss had occurred. Health workers described to me how they would at times try to keep women at the hospital if they believed she'd had an illegal abortion. Some health professionals told me that women were threatened with the withholding of care, including pain medication, until they revealed what happened. When there's pain, a nurse told me at one of the study hospitals, women will talk. Health workers were more likely to suspect young, low-income, and unmarried women of illegal abortion and would amplify their efforts to question the patient, or what they would call pushing the interrogation. For example, while treating a woman who'd arrived alone at the third study hospital, health workers continued to ask her about the whereabouts of her husband. Now, why do health workers interrogate women? Why do they attempt to determine whether the patient had a miscarriage or an induced abortion? Very real possibility that the police may catch wind of the case and come to the hospital to investigate. So here we see a newspaper report of a case in 2011 involving a woman who was arrested for illegal abortion. She'd received an abortion from a nurse at a hospital in another region of the country. When she began to bleed profusely, she sought care at a district hospital and was evacuated to a larger hospital in Dakar. Suspecting an illegal abortion, the doctor called the police. After 2 days of observation, she was transported in the hospital ambulance to the police station. In a case prosecuted by the Regional Tribunal of Dakar in 2009, a physician called the police after a young woman presented at his facility with complications of abortion. The police came to the hospital, interrogated the patient, and subsequently escorted her to another facility where health workers conducted an ultrasound and concluded that she had attempted an abortion. And what we see here is the report from that ultrasound. Sometimes the police receive anonymous tips about suspected illegal abortions. In another case prosecuted in 2009, the police arrived at a district hospital within 2 hours of being tipped off about a patient who was being treated for complications of illegal abortion. After conducting a bedside interrogation, the police requisitioned a medical report from the attending physician, shown here, which concluded that she had terminated a pregnancy. According to the police report, she confessed to the police that she had swallowed a homemade infusion and was eventually sentenced to 6 months in prison. Obstetric violence also emerges from national and global abortion policies that shape the management of post-abortion care technologies in hospitals. USAID provides funding to train health workers in MVA, but doesn't support the procurement of MVA because of the 1973 Helms Amendment. And in Senegal and other countries with restrictive abortion laws and PAC programs, health managers and hospitals have to procure MVA on their own. International NGOs have donated supplies, especially during the early stages of PAC programs, but these sources eventually vanish, leaving hospitals and health systems on their own to figure out how to purchase and distribute the syringe, which is still considered a preferred post-abortion care technology. The national prohibition on abortion engenders MVA policies that aim to prevent the misuse of MVA for illegal abortion, but that ultimately reduce women's access to quality post-abortion care. For example, the MVA syringe is the only medical item that cannot be procured through the national medical supply system. And so hospitals in need of a new syringe have to send a representative to Dakar, receive a stamp of approval from an official in the Ministry of Health, and then purchase the syringe at the headquarters of an NGO, also in Dakar. And this very burdensome procedure delayed the timely renewal of MVA syringes, thereby contributing to the presence of malfunctioning devices in daily obstetric practice. Hospitals enact their own rules to prevent the abuse of MVA technology. Although she had several MVA syringes in her office, the gynecologist at the second study hospital permitted only one MVA syringe to circulate among 4 shifts of midwives. And so the midwives complained about how this MVA syringe often didn't work. And delays in care often occurred as midwives disassembled and decontaminated the syringe after each use. At the third hospital, the head gynecologist restricted MVA services to weekday mornings and afternoons when senior physicians were available to supervise the use of the device by junior physicians. And so patients who arrived at night or on the weekend were treated with other methods, such as DNC or digital evacuation, which is displayed in the image on the bottom right. And this procedure was often performed without pain medication, and in some cases without gloves. It is not a method of abortion care that is recognized by the World Health Organization, yet it has been documented throughout sub-Saharan Africa, both in facilities lacking MVA equipment and trained personnel and in health facilities that are equipped with these resources. So I've just talked about how organizational and clinical practices and legal frameworks give rise to obstetric violence. And so I'd like to discuss now how strategic measurement practices related to PAC may perpetuate bodily and structural harm against women. The table on the top right-hand corner shows that in the 3 hospitals where I observed PAC, almost all PAC cases were classified as spontaneous abortion. And this is not unusual. Health workers in countries with restrictive abortion laws may be reluctant to disclose that they provided abortion or even that they provided PAC. Many of the health workers I interviewed indicated that they preferred to record suspected cases of illegal abortion as spontaneous abortion to avoid initiating or becoming embroiled in police investigations. And so these record-keeping practices were also grounded in health workers' beliefs that they were primarily responsible for addressing the clinical management of abortion complications rather than the legal implications of clandestine abortion. In the short term, however, these practices may protect women and health workers from police intervention at the hospital, although the newspaper stories I shared earlier suggest that providers do not always have control over how the police learn about cases of illegal abortion being treated at the hospital. In the long term, these practices portray post-abortion care patients as women who've experienced the miscarriage of a presumably desired pregnancy, thereby reinforcing abortion stigma or discriminatory attitudes and practices towards women who are suspected of having had an abortion. And so while patient interviewing is a standard part of medical practice, the discriminatory elements of l'interrogation that give rise to abortion classifications and that are out of step with PAC's ethic of harm reduction are not captured by the record. At an institutional level, these interpretations of the kinds of women treated are reproduced by decisions about routine data collection across multiple levels of the health system. So while health workers sometimes specified abortion type, the Ministry of Health does not routinely collect this information, focusing instead on the number of cases treated, the proportion treated with MVA, and the proportion who received family planning, counseling, and a method. And so PAC data thus generate a sanitized account that frames the intervention as one that is primarily concerned with saving presumably expectant mothers. Omitted from this account is the poor quality of care experienced by women, regardless of whether they've experienced spontaneous or induced abortion, or the difficulties encountered by health workers as they try to provide care within a context where abortion is altogether prohibited. Strategic measurement practices also shape the portrayal of the technical management of post-abortion care. When I reviewed PAC records at all 3 hospitals, I found that over time, MVA became the most frequently used method of uterine evacuation. Yet at all 3 hospitals, health workers continue to use digital evacuation. The graph here shows data from 2010, and we see that digital evacuation accounted for over 37% of PAC cases in the first hospital, 26% in the second hospital, and 13% in the third hospital. And again, these study hospitals were authorized to use MVA and staffed with health workers trained in MVA. More recently, a 2016 National Report of Obstetric Care estimated that 73% of health facilities had MVA. So these data are encouraging, but they say little about how many functional devices are available at each facility or the proportion of PAC patients that are treated with digital evacuation. Health workers very carefully document which methods they use to treat their patients, but it is the numbers on NVA and not digital evacuation that are collected by the Ministry of Health and then taken up by NGOs and donors in national and global evaluations of PAC. These are the numbers that matter most in conveying quality of care, in conveying that PAC works and is an effective maternal health intervention. And so in reports of PAC published by NGOs, funded by USAID, digital evacuation is often completely omitted from the account. In a global review of 20 years of post-abortion care evidence published with USAID support in 2016, there's no mention at all of digital evacuation. I want to return to this 2018 survey of post-abortion care published in the Lancet Global Health. Senegal was actually included in this study, and the data from Senegal are displayed in the third column from the right. And Senegal actually demonstrates pretty good indicators with respect to uterine evacuation. 84% of primary care facilities and 86% of referral level facilities reported the capacity to conduct uterine evacuation. But these indicators do not distinguish between the types of uterine evacuation techniques practiced at these facilities. Are we talking about NVA? Are we talking about curettage? Or are we talking about digital evacuation? More recent PAC data suggest that these services are incredibly expensive and remain out of reach for the poorest women. A 2021 national study estimated an average a study published in 2020 that had a national sample estimated an average out-of-pocket cost of about $27. Whereas a more recent study published in 2021 that was conducted in the region of Dakar estimated an average out-of-pocket cost of about $94, which represented about 15% of the study participants' salary. Post-abortion care services with misoprostol were cheaper than dilation and curettage and MVA, but still quite high at 62%. Quality of care is still a problem. Digital evacuation and DNC are still being performed despite the availability of MVA and misoprostol. And pain medication may not be routinely administered. Only a third of patients recalled receiving pain medication, and women who did receive pain medication paid about 30% more. Since the introduction of PAC in the late 1990s, Senegal has experienced a modest decline in its maternal mortality ratio. And while health managers can assess the quality of care offered to women by PAC programs, it's very challenging to determine the impact of post-abortion care on national estimates of maternal mortality and morbidity, right? For one thing, women who receive post-abortion care in hospitals are just a fraction of women who've had abortions. And also, abortion-related mortality and morbidity are often recorded as something else, right? Despite a lack of statistical evidence of PAC's effectiveness, the strategic deployment of certain PAC indicators, the number of women treated and the proportion treated with MVA, ensures continued financial and technical support for PAC in a global health landscape where donors want to see numbers, to use the words of medical anthropologist Noel Sullivan, that go up. The invisibility of techniques like digital evacuation and l'interrogation must be situated within a neoliberal landscape of global reproductive governance in which some indicators are privileged over others in the portrayal of maternal health care, and in which donors increasingly prioritize the development of ever more sophisticated estimates of maternal mortality over health systems strengthening. The imperative to demonstrate rising PAC indicators again is revealed in this 2018 commentary published in the Lancet Global in the Lancet Global Health, right, which was essentially urging more PAC. Critical scholars of global health have argued that health professionals and medical authorities in developing countries negotiate multiple numerical truths as they strategically manage metric uncertainties and inconsistencies to demonstrate the legitimacy of their work and to maintain accountability to national and global health priorities. Within a transnational policy landscape that has rejected safe abortion from maternal and reproductive health mandates, I argue that Senegalese health experts have very pragmatically interpreted data on hospitals' capacity to save women's lives as evidence that something is being done about maternal mortality and morbidity in Senegal. They have enabled the ministry to comply with the ICPD's framework for rights-based maternal mortality reduction while adhering to the national abortion law. These metrics demonstrate the intervention's compliance with and eligibility for the anti-abortion funding of the government's primary reproductive health donor, the USAID, which in 2016 spent $60 million on its population policy and reproductive health sector in Senegal. Engagement in post-abortion care, research, programming, and advocacy conferred global recognition of a commitment to reproductive health and rights on health authorities and NGOs, which led to more funding for post-abortion care. It paid quite literally to keep women alive after they had resorted to unsafe, illegal procedures, despite a lack of epidemiological evidence that post-abortion care reduced maternal mortality. Post-abortion care is also intricately interconnected with other global regimes of reproductive governance. And as influential donors like USAID and Gates actively facilitate a return to the target-oriented approach of neo-Malthusian population control, Senegalese post-abortion care patients represent a very lucrative new consumer base for long-acting reversible contraceptives that are widely understood as not only as medically controlled solutions for reducing fertility, but also a form of averting maternal death. Along with Uganda, Niger, and Burkina Faso, Senegal was a testing site for Sayana Press, and this image seems to be blocking some of my text on the slides. Sayana Press, again, is a self-administered form of Depo-Provera. Between 2014 and 2016, over 120,000 doses of Sayana Press were administered in Senegal. In fact, the USAID clarified to Gates, which also refuses to support abortion-related activities and services, that PAC is not abortion in order to bring Gates on board with using PAC to increase contraceptive uptake under the FP20, the Family Planning 2020 initiative. Through these indicators, national and global PAC stakeholders, to use the words of medical anthropologist Cal Baruch, see exactly what they intend to see, even if these accounts are profoundly incongruent with the clinical realities of PAC for health workers and patients, and suppress political will to revise a discriminatory abortion law. If life-saving PAC services, including contraception, are in place and most PAC cases are related to miscarriage, then there is little need to revise the abortion law. I believe I'm running out of time, so I'm going to skip over some of this, but essentially just to sum up, even if post-abortion care's contribution to maternal mortality is difficult to quantify, public health experts have long known the public health impact of safe, legal abortion, right? Abortion mortality goes down in countries in the global north and south that have liberalized abortion. The global gag rule has not led to reduced abortion incidence. It has actually increased abortion incidence. And we actually have quite a bit of data on the cost, the staggering cost of post-abortion care around the world. An estimated $232 million are spent every year in developing countries on post-abortion care. PAC is actually more expensive for women than safe abortion. Women in Zambia, for example, pay 2.5 times more for post-abortion care than they do for safe abortion. In Nigeria, they pay about 4 times more for post-abortion care than they do for safe abortion. Post-abortion care's political staying power and recent calls for more post-abortion care by national and global health experts in the face of decades of evidence showing that legal abortion reduces abortion-related mortality and that post-abortion care is much more expensive for women than safe abortion illuminate the disposability of women's bodies in achieving the targets that matter in global reproductive governance. Post-abortion care normalizes survival following unsafe abortion as a marker of reproductive well-being. And it's precisely because post-abortion care has been portrayed as good enough for low-income women of color in the global South that little attention has been directed to the violent, discriminatory nature of women's encounters with these services or to assess the extent to which PAC actually reduces abortion-related deaths. PAC has been framed in the language of reproductive rights, but it actually represents a profoundly unjust form of reproductive governance that withholds safe, legitimate obstetric care from Senegalese women until after they have resorted to unsafe procedures and then punishes them in hospitals for transgressing gendered expectations of motherhood with threats, humiliation, and poor quality of care, while at the same time rewarding the NGOs, pharmaceutical companies, and government authorities responsible for the costly services required to keep PAC patients alive and contracepting. Seemingly benign measurement practices reinforce these inequalities by obscuring what happens and who is treated in hospitals and how. And while these practices secure support for PAC as an effective maternal health intervention, they foreclose opportunities to revise the abortion law and to improve obstetric care more comprehensively. So I want to be clear, I'm not calling for an immediate termination of PAC or other harm reduction strategies related to maternal health. As long as abortion laws remain strict and abortion stigma remains high, there will be a need for PAC. And there is a need for PAC in wealthy countries like the United States. For example, in 2015, Anna Yoka was taken to an emergency room in the state of Tennessee after she used a coat hanger in an attempt to terminate her pregnancy of 24 weeks. We are witnessing an intensification of abortion restrictions, most recently illustrated with the abortion law in Texas, through which post-abortion care may become the new normal of abortion care for the most marginalized women in the US. I advocate for a commitment to reproductive justice that critically situates PAC within multiple and contradictory regimes of national and global reproductive governance, in which various actors, including government health authorities, aid donors, and NGOs, are motivated to achieve goals that are not always aligned with women's needs and interests. PAC's capacity to keep women alive does not mean that we should not be critical of how interventions that, in the words of medical anthropologist Gordon Rowe, are better than bad, may foreclose opportunities for reproductive justice that put women first. I call for a critical engagement with the racialized and gendered entanglements in the governance of reproductive health and resulting health outcomes between the global North and South. Trump signed the global gag rule in 2017, 3 days after taking office. However, state and federal policies in the US have long restricted the reproductive autonomy of low-income women and women of color in the US. Black and Native American women who carry their pregnancies to term continue to face disproportionately high rates of maternal mortality and morbidity. And this is in line with a long history of policies and discourses that have framed women of color as bad mothers, irresponsible and overabundant breeders, and less deserving of quality maternal and reproductive health care. Policymakers and other stakeholders must be held to account for how they interpret and act on data related to abortion. Policymakers in countries like Ethiopia and Mozambique and Nepal relaxed abortion laws precisely because they were looking at the burden of induced abortion in maternity wards. Of course, legal reform does not immediately translate into the elimination of clandestine abortion, right? This is the case in South Africa, which has one of the most liberal abortion laws on the planet, but legal abortion is an important start. More generally, there's a need for critical examination of numbers and indicators in global reproductive health. Which numbers count and why? What are we missing with our measurement practices, and what can we do? What can we do better? Also important, how can we more equitably distribute resources for reproductive health research to actors and institutions in the global South? And this is an area that I'm actively engaging in my current research on misoprostol in West Africa. Who gets to participate in the production of knowledge about reproduction? Finally, a reproductive justice approach demands that our measurement practices and policy choices ultimately center women's needs, comfort, safety, and dignity, and confidentiality when it comes to reproductive health care. To what extent are we investing in quality, affordable reproductive health care throughout the healthcare system? And this includes the availability of trained health workers operating in supportive clinical environments. In other words, a reproductive justice approach demands a serious commitment to strengthening health systems. So I'll stop there, and I look forward to your questions and comments.
That was great, Siri. Thanks so much for that talk and for taking us over so many incredibly important issues. So we only have a few minutes left, and so I just wanted to open the floor to questions from either people who are in the room in person or in the chat. I think we have a question. Oh, you're gonna go with James?
Oh, go ahead. Who? Colin, yeah.
Thank you for the really interesting presentation. A number of years ago, I think Senegal was one of the success stories for the introduction of misoprostol. And I think there was a lot of hope that it would accelerate the decentralization of post-abortion care to primary care settings and make the service more available. And you mentioned actually that PAC is not widely available in primary care settings in Senegal, and you're focusing your new research on that. And I was wondering if you could explain what have been some of the reasons why the introduction of misoprostol for PAC hasn't resulted in greater availability of PAC in settings closer to communities where it could be more easily accessed by women.
Colin, can you just indicate that you're Baines et al.?
I am Baines et al. From slide, the costing study in Dakar, yeah.
Great question. The story of the manual vacuum aspiration syringe is really instructive in, kind of thinking about the challenges that have been presented in terms of making misoprostol available in public health facilities for approved obstetric indications. So yes, misoprostol has been integrated onto the national list of essential medications. There's been some training of health workers on how to use misoprostol for post-abortion care and also for managing postpartum hemorrhage, but it is very difficult for health managers and hospitals to procure misoprostol, right? Even though unlike the MVA syringe, it is part of the national pharmaceutical supply system, health managers are very leery about procuring a drug that can be used to administer abortions. What we also see is that post-abortion care services administered through misoprostol are not significantly cheaper than those administered through manual vacuum aspiration, right? In Senegal, it's about $63, right, for misoprostol services. In other countries, MVA can cost over $200. There was a study that recently came out that said, I think it was in Colombia, that MVA cost over $200, right? So again, post-abortion care is a model that has been around for a long time, right? And that gets a lot of praise and applause. But when we look very carefully at what women are experiencing and what they're paying in health facilities, we see a very different story.
So, sorry, I'm going to ask James Pfeiffer to step in. Ask his question.
Okay, can you hear me?
Yes.
Yeah.
Okay, hi everybody. And Dr. Sue, thank you for a really, really wonderful talk. That was really terrific. I just put a question in a chat as well, kind of a basic question about how universal health coverage might be being rolled out in Senegal and how it's affecting costs for reproductive health services. It was alarming when you talked about how expensive it seems to be for many women to actually pay for these services. And just wondering what the broader context is for universal health care in the UHC, the SDG idea. I just heard an interesting talk about Kenya, where the way that insurance is rolling out is quite a disaster and leading to even higher out-of-pocket costs for people. And I'm just curious if what you're seeing in Senegal around that.
Right. Well, at the time that I did my research, there was some coverage for delivery care, and specifically cesarean section. To my knowledge, there was no coverage of post-abortion care, although these services were supposedly, the costs were supposedly suppressed, right? So the actual cost of the manual vacuum aspiration syringe was mandated at 10,000 CFA, right? But women coming in for services have to pay for the rubber gloves that the health workers use. Otherwise, they won't provide care. They have to come with their own bottle of bleach to disinfect the equipment. They have to come with essentially all of the material that the health workers are going to use in addition to medication, right? So the out-of-pocket costs for post-abortion care remain extremely high. And that I'm not sure if the costs that I talked about earlier took into account transportation, right? Sometimes, if women first go to a primary level facility and they determine that she needs to be referred, if they don't have manual vacuum aspiration, then of course it's the woman who has to pay for transportation to the district hospital. When I was at the doing research at my second study hospital, which was a district hospital, the gynecologist was at a training program in Morocco. So there was no gynecologist at the hospital. So she had to go to the regional hospital, maybe an hour's drive away, but she couldn't get there because the ambulance had no fuel and she had no money to pay for the fuel, right? So she had to stay at the hospital until her family, kind of gathered together some money to buy fuel for the ambulance. So beyond the actual services, there are costs that are usually taken on by patients and their families.
Thanks for that talk, disturbing dynamics. But thanks again, great, wonderful lecture.
I'm going to invite Farhana to unmute.
Hi, Dr. Sue. You mentioned that one of the hospitals had a tight constraint about when they would perform PACs, and they often used digital evacuation methods at night. So in that hospital, does data exist on any post-impact infections on women who have gone through digital evacuations, and has the local government overseeing that hospital taken action against that?
Mhm. That's an excellent question, and the risk of infection following digital evacuation was a major kind of push factor for introducing the manual vacuum aspiration syringe, right? Digital evacuation is a method that has been around for a really long time. One of my gynecologist key informants described it as an archaic method that people were using 100 or 200 years ago, right? But again, this is something that is still being used and was still being used in the early 90s when the MVA syringe was introduced. So the introduction of MVA was kind of promoted as a way of reducing these infections that were being documented by health professionals. I did not, in my review of the records, I did not follow women to see whether they came back to the facility with complications following treatment. And the sad reality is that many women do not come back for follow-up care. But it definitely is a problematic reality that decades after the introduction of this model that was supposed to be technologically advanced and safer for women, that digital evacuation continues to be used, and that health workers are in a position where they essentially have to use digital evacuation because the manual vacuum aspiration syringe is locked up, or they have a backlog of patients and the MVA syringe is being decontaminated, right? And so what else can they do? They have to use their fingers, right? So the persistence of digital evacuation is kind of very much embedded in the under-resourced nature of many maternity wards in public hospitals.
Well, thank you. Let's give Dr. Sue another round of applause. Thank you so much. Thank you. Glad to see you, Nora. We do have a post-seminar discussion. There's a link to that chat here if you'd like to join. And thank you to all our sponsors. And again, thank you for staying up very late, Dr. Sue, to give your talk. It's wonderful, although very profoundly upsetting but important work that you're doing. So for those of you, we had one of our best attendances for our seminar because of you, and we're grateful for that. Thank you.
All right, thanks everyone. Have a great evening or afternoon.